Cardio-Oncology was developed in collaboration with the European Hematology Association, the European Society for Therapeutic Radiology and Oncology, Therapeutic Radiology and Oncology, as well as the International Cardio-Oncology Society. So this will be my outline for the presentation. So we'll have an introduction and look at some definitions, how to classify chemotherapy-related cardiovascular toxicity, baseline risk assessments. We look at screening and monitoring tools, and then how to manage chemotherapy-related cardiac dysfunction. We also talk about cancer-associated thrombocytosis, radiotherapy, and then coronary artery disease. And then we look at the conclusion. So this wouldn't cover all the contents of the guideline. This is a frequently displayed slide showing the various classes and level of evidence. So just by way of revision. So this guideline is the first ESC guideline on cardio-oncology. And the guideline and its recommendations are to facilitate decision-making of healthcare professionals in their daily practice. However, these guidelines are not substitutes for patients' relations with their practitioners. And we should always remember that the final decision concerning an individual patient must be made by the health care practitioner based on what they consider to be the most appropriate in the circumstance. And these decisions should be made in consultation with the patient and or their caregiver where appropriate. The aim of this guideline is to help healthcare professionals who provide care to oncology patients before, during, and after their cancer treatments for their cardiovascular health and wellness. Again, it provides guidance on definitions, how to make diagnosis, treatment options, and then how to prevent cancer therapy-related cardiovascular toxicity and the management of cardiovascular disease caused either directly or indirectly by the cancer itself. I must also mention that cardio-oncology has limited trials and evidence on which to base most of the decision making. So where evidence is limited, this guideline provides a consensus based on experts' opinion. Early detection and treatment of cancer, as we all know, have led to improved survival of patients, and at the same time has also increased treatment-related complications. And cardiovascular disease are one of the most frequent of these side effects, and they may lead to premature morbidity and death among cancer survivors. Cancer therapy has been linked to myocyte damage, as well as hypertension, left ventricular dysfunction, heart failure, and other conditions which we will look at later. It involves a direct effect of the cancer treatments on the heart structure as well as the function. And cancer therapy-related cardiovascular toxicity occurs in about 10% of patients. And chemotherapy may accelerate the development of cardiovascular disease, especially in patients who have traditional cardiovascular risk factors already. And this damage may be reversible. In some cases, it is permanent. So for this reason, risk assessments, recognition and prevention of CTR, CVT are very crucial. And the management of cancer therapy-related cardiovascular toxicity has a tremendous impact on morbidity and mortality outcome of patients with cancer. Again, the effective management of patients with both cancer and cardiovascular disease require a unique interest and expertise of healthcare providers, which have led to the formation of the discipline for the cardio-oncology. And the goal of cardio-oncology discipline is to allow patients with cancer to receive the best possible treatment safely whilst at the same time minimizing its side effects across the entire continuum of their cancer care. So these are some of the aspects of cardio-oncology service. So cardio-oncology service aims to monitor for early cardiotoxicity. It also aims at preventing primary prevention of cardiovascular toxicity in high-risk patients, and also secondary prevention of cardiovascular toxicity. It also includes investigation of suspected cardiac invasion by tumor. It also includes preoperative assessments for cancer surgery and also management of other cardiovascular toxicities. So the diagram mainly shows the various chemotherapeutic agents, their mechanisms of action, and also outcome of the therapy if no action is taken when there is a side effect. So it can lead to left ventricular dysfunction, heart failure, hypertension, and atherosclerosis. So we'll look at this diagram in the details later. So when we come to definitions, several terminologies and definitions have previously been proposed to describe the spectrum of cancer therapy-related cardiovascular toxicity. And this led to inconsistencies in diagnosis and management. So basically, cancer therapy-related cardiovascular dysfunction was broadly used to cover asymptomatic cardiac dysfunction as well as symptomatic heart failure that is attributed to the various cancer therapies. And this includes chemotherapy, immune therapies, as well as radiotherapy. And current definition of CTR-CD are now based on a reduction in the LVEF and or a relative change in global longitudinal strain or GLS or increase in cardiac biomarkers. So when we talk about cancer therapy related cardiovascular toxicities includes the following that have been listed. This includes vascular toxicities like coronary artery disease, peripheral artery disease, TIA, strokes, and venothromboembolism. It also includes arterial hypertension, pulmonary hypertension, arrhythmias, QT prolongation, pericardial disease, and then valvular heart disease. So as mentioned earlier on, there had been various definitions for cancer therapy dysfunction, and these are some of the previous definitions. So on subsequent slides, we look at the current definition. So I wouldn't go through this. We can always refer to it, but these are previous old definitions. So focus more on the current one. So the 2022 ESC Cardio-Oncology guideline refines the CTR-CD definitions by incorporating the EF, GLS, and cardiac biomarkers. CTR-CD can be asymptomatic, where the dysfunction is usually detected via imaging such as echocardiogram, or when we do biomarkers. These biomarkers are BNP and troponins. So when we talk about asymptomatic CTR-CD, it's graded based on changes in LVEF, and this must be in the absence of signs or symptoms of heart failure. So we have mild, moderate, and then severe CTR-CD. So mild usually refers to where your ejection fraction is normal, and in this case, normal means 50% and above. So we have a normal EF, patient is asymptomatic, but when you do the global longitudinal strain, you find that there will be a 15% reduction as compared to the baseline EF, if there was a baseline EF, or when there is a new elevation in cardiac biomarkers. But in terms of the cardiac biomarkers, there's really no cutoff point where we can say, for instance, if the troponin elevates by 2 times or 3 times, it's diagnostic. since any elevation in troponin compared to baseline is considered significant. And moderate CTR-CD is where you have an EF between 40 and 49% with concurrent reduction in the GLS or an increase in the cardiac biomarkers. Severe asymptomatic CTR-CD is where patients have no symptoms and the EF is below 40%. And this is regardless of elevation in GLS or changes in the biomarkers. And then we look at the symptomatic form. So for the symptomatic, the mild symptomatic is where patients present with symptoms of heart failure, but they do not require heart failure intensification, heart failure therapy intensification. And moderate symptomatic CTR-CD is where there is a need for an outpatient diuretic and heart failure therapy intensification. So the moderate ones can be managed on OPD without admission. Then you have the severe symptomatic, and this is where patient has symptoms of heart failure and they will require hospitalization for further treatment. And then lastly, we have the very severe CTR-CD. And this is where patient is symptomatic and they will require inotropic support or mechanical circulatory support, or in some rare cases, they may even require heart transplantation. So how do we classify chemotherapy-related cardiovascular toxicity? This is mainly based on the time during treatment at which the side effects occurred. So we have acute, subacute, and then chronic. And the acute toxicity usually occurs within a week to about 3 weeks. And this usually involves AV, atrioventricular abnormalities, arrhythmias, prolonged QT, pericarditis, and myocarditis, and is the rarest form of the cardiotoxicity. Then we have subacute. Subacute usually occurs anytime between the onset of the commencement of the treatment up to 1 year into the therapy. And this occurs in about 1.6 to 2.1% of the patients. And then lastly, we have the chronic or the late onset, which is the most common, and usually occurs in about 1.6 to 5% of patients. And this occurs after a year and may even occur later in life, up to about 20 years after the chemotherapy. Okay, so now how do we recognize cardiovascular toxicity? Identify whether patient is likely to have chemotherapy-related cardiac dysfunction or not. And in the history, we want to identify the presence or absence of pre-existing cardiovascular disease, and also primary and secondary prevention strategies. And this also includes a baseline cardiovascular risk, sensitivity risk assessment. So in the history, one of our focus is to look at the patient's age, patient's gender, patient's medical history. And the focus here is to focus on cardiovascular risk factors, and also look at patients' lifestyle risk factors. Do they take alcohol? Do they smoke cigarettes or tobacco? We also want to focus on their previous cardiovascular, previous cardiotoxic therapies, if they've had cancer before and whether they were on treatment. Okay, so this is one of the tools that is mainly used for the baseline risk assessment. That's the Heart Failure Association of the ESC and the International Cardio-Oncology Society risk stratification tool. So these two looks at various baseline risk factors. So when we look at the first column on this table, we have various baseline risk factors. So for instance, here we have age, cardiovascular 10-year cardiovascular risk assessments for hypertension, chronic kidney disease, proteinuria. You know, this slide. You also look at their cardiac imaging values. What is the ejection fraction? Their cardiac biomarker values, and then whether they've had history of heart failure before, MI, have they had PCI or CABG in the past. So basically, we have to look at the baseline risk factors, and then for the next column on the table, we look at the drug that the patient is going to be put on. So for instance, the patient is going to be given anthracycline, which is on the second column here. We have to look at the patient's age. So if the patient is above 80 years and above, then we have to assign that as H. And H here means high risk. When we see M, it means a moderate risk. And moderate risk can be either moderate 1 or moderate 2. When we see VH, then it's a very high risk. So we need to go through all these parameters and then get a score for the patient. So the score value would determine whether the patient is at low risk, moderate risk, or high risk. So we'll look at that on the subsequent slide. So as part of the baseline cardiovascular risk assessments, we have to look at, again, the cardiovascular risk factors, cardiovascular disease history, cancer history, cancer treatment history. And then doing an ECG at baseline as a class 1 indication. You also have to focus on physical and metabolic assessments to help determine the patient's level of risk. How to try and identify whether they have a pre-existing cardiovascular disease or whether they are at risk of chemotherapy-related cardiac dysfunction. And this is mainly based on their troponin levels or natriuretic peptide levels, and also based on their transthoracic echo values, as well as reduction in the global longitudinal strain. So based on the values we'll get from the table that was shown earlier, patients is classified as either low risk, moderate, high, or very high risk. And the low risk patients are those who have no risk factors or have at least one moderate one risk factor. And for these patients, their future cardiovascular risk is low, it's less than 2%. And they are usually continued on treatments with cardiovascular surveillance as appropriate. And this will be based on local or national guidelines if available. Otherwise, they will have to be based on international guidelines. For those with moderate risk are those who score between 2 to 4 points. And for these patients, their future cardiovascular risk is between 2 to 9%. And they will require a closer monitoring of their cardiovascular health during treatment as compared to those who have the low risk. And these patients should also be referred for cardio-oncology or cardiology assessments. And this is mainly to help modify and treat their underlying cardiovascular disease or risk factors. So for those classified as high risk, they will have multiple moderate risk factors with a total of at least 5 points or at least any one high risk factor. And their future cardiovascular risk is also higher, usually about 10 to 90% chance of developing a cardiovascular during their treatments. And then lastly, we have the very high risk patients. These are patients who will have any high risk factor, and their future cardiovascular risk is high, above 20%. And these patients should be referred for cardio-oncology and cardiology assessment to optimize their management of any pre-existing cardiovascular disease and also modifiable cardiovascular risk factors. And there must always be a multidisciplinary team discussion requiring a balance between the treatment efficacy and the safety of the medication they are going to be given. And again, for those who are high and very high risk, we should always consider switching to a less cardiovascular cancer treatments where that is available. Okay, so still on the patient's care, sharing with the care of patient with cancer. So cardiovascular risk stratification before cancer treatment has a class 1 indication. And the use of the Heart Failure Association and the International Cardio-Oncology Society baseline risk assessments should be considered because it has a class 2A indication. So based on the this assessment tool, as mentioned earlier, patient can be classified as low risk, moderate risk, high or very high risk. And for those who are classified as low risk, we'll go to routine cardio-oncology follow-up and will only be referred for cardiology assessments when they develop any cardiovascular toxicity. For the moderate risk patients, as in those in the middle, they will require closer cardio-oncology follow-up and also need cardiology referral if cardiovascular toxicity develops at any point. But before that, you may also consider referring for cardiology assessment even before they develop any toxicity. So this basically shows the cardio-oncology care pathway from when a diagnosis is made during cancer treatments, the first year after cancer treatment, and then long-term follow-up. And in this care pathway, the care depends again on the baseline risk assessments. So for low-risk patients, they will require standard surveillance, and then during the treatment, they require the standard surveillance. And then during the first year after cancer therapy, they will require assessments at 1 year after completion of the cancer therapy. And for long-term follow-up, they require annual cardiovascular risk factor assessments, and they should be reassessed if new cardiovascular symptoms occur. And for moderate risk patients, during the treatment, they have to be referred for cardiovascular assessments. And then during first year after cancer therapy, assessment at 1 year after completion of the cancer therapy is required. And for their long-term follow-up, they will require annual cardiovascular risk factor assessments and cardiovascular toxicity risk stratification at 5 years. Again, they also require transthoracic echo assessments every 5 years. And for those at high and very high risk, they must be referred for cardiology assessments for cardiovascular disease prevention during the treatment. And also during the first year after the treatment, they require assessment at 3 months and 1 year after completion of the cancer therapy. And for their long-term follow-up, they will require transthoracic echocardiogram at year 1, year 3, as well as year 5. And thereafter, they require transthoracic assessments, echocardiogram assessment every 5 years. So this shows the various recommendations. Actually, I've mentioned most of these already. So the first one, cardiovascular toxicity risk stratification before starting potential cardiotoxic anti-cancer therapy is recommended in all patients with cancer. This has a class 1 indication. And communicating the results of the cardiovascular toxicity risk assessment to the patients and other appropriate healthcare professionals is also recommended with a class 1 recommendation. The use of the Heart Failure Association and International Cardio-Oncology Society risk assessments should be considered to stratify cardiovascular toxicity risk in patients with cancer who are scheduled to receive cardiotoxic cancer therapy. So I'll skip the rest because it's been mentioned already. So we'll now look at how to screen and also monitor patients before and during the cancer therapy. So the first two is electrocardiogram and a baseline ECG, usually 12-lead ECG, provide important clues to an underlying cardiovascular disease. On the ECG, you may have evidence of chamber enlargements. You may have evidence of conduction abnormalities, arrhythmias, either atrial fibrillation or flutter. You may also take evidence of ischemia or prior MI on the ECG. So a baseline ECG is recommended before starting cancer treatments, so those known to cause QT prolongation. And ECG recommendation in all patients starting cancer treatment as part of their baseline assessments as a class 1 indication. And patients with abnormal ECG should be referred for cardiologist assessments. This also has a class 1 indication. And then apart from the ECG, there's also the need to do cardiac biomarkers as a baseline assessment. And there is limited literature on the use of these biomarkers for cardiovascular toxicity risk assessment. So because there's limited literature, usually what to do is based on experts' opinion, and there are no specific cutoff points above which the biomarkers are considered significant. So currently, any elevation in the cardiac biomarkers compared to the baseline is considered significant. And patients with cancer with an increase in cardiac troponin before treatments are more likely to develop cancer therapy-related cardiac dysfunction. So doing these biomarkers as baseline has a class 1 indication. And then the next screening and monitoring tool is cardiac imaging. And this is plays a very vital role in identifying patients with subclinical cardiovascular disease. It helps determine the degree of pre-existing cardiac comorbidity and also serve as a reference for identification of any change that occurred during treatment, as well as during the long-term follow-up of the patient. And the frequency at which these imaging are done is usually individualized, based mainly on the patient's baseline risk level. And early recognition of asymptomatic CTR-CD allows the incorporation of cardioprotective therapy before there is any significant decline in the LVEF. So the most recommended imaging tool is the transthoracic echocardiogram. And this provides quantitative assessments of both the left and the right ventricle. It also gives information on whether there's any chamber dilatation, whether there's hypertrophy. Echo also helps in identifying wall motion abnormalities. Again, it can also help to pick up diastolic dysfunction if present, as well as valvular heart disease. It can also help to measure the patient's pulmonary artery pressure, since some of the chemotherapy drugs can cause pulmonary hypertension. So the next imaging tool is a global longitudinal strain. So this is mainly an AI assessment of the myocardial contractility, and it's able to assess all the 17 segments of the
left ventricle. So when we do the global longitudinal strain, it will usually give figures or assign figures to each of the segments. And the normal GLS is usually between -18 to -22. And what the GLS does is mainly to track each of the myocyte fibers and assess how it shortens during systole. This slide shows the global longitudinal strain of a patient at baseline, during the treatment, and also after treatment. So for this particular patient at baseline, the patient had an EF of 60%, which was normal, with a GLS of -19.9, which was also normal. However, during the treatment, so this patient was on trastuzumab. During the 11th cycle of trastuzumab, when the patient was reassessed, the EF had dropped to 56%, which was still within normal range. However, the GLS had dropped to 14.2%. So when we compared the 40.2 to the baseline of 19.9, it had dropped by about 28%. So by our earlier definition of mild chemotherapy dysfunction, cardiac-related dysfunction, this patient had a mild asymptomatic disease and was put on cardioprotective therapy. Treatment was able to continue to completion. And at the end of the treatment, the patient's EF had recovered and the GLS had also improved. So this shows how significant the global longitudinal strain is in patients' assessment. Without doing the GLS, we may miss supplemental dysfunction. The patient may continue the treatment without any intervention and later develop cardiac dysfunction, which will result in interruption in their therapy. So we'll now look at the various recommendations on the imaging modalities. So a baseline echocardiography is recommended in all patients with cancer before anthracycline chemotherapy, and also in all adults receiving anthracycline chemotherapy. An echocardiogram is recommended within 12 months after completion of the treatment. In high risk and very high risk patients, echocardiography is recommended every 2 cycles and within 3 months after completion of their treatments. And all these have a class 1 indication. However, in patients with moderate risk, additional echocardiogram should be considered after they have received an accumulative dose of at least 250 milligram per meter square of doxorubicin or its equivalent. And in patients with low risk, an additional cardiography may be considered after accumulative dose of at least 250 milligram per meter square of doxorubicin or its equivalent has been given. And then on the cardiac biomarkers, a baseline measurement of natriuretic peptide or cardiac troponins is recommended in high and very high risk patients prior to anthracycline chemotherapy. And this also has a class 1 indication. And a baseline measurement of natriuretic peptide or cardiac troponin should be considered in low and moderate risk patients prior to anthracycline chemotherapy. And again, troponins and the natriuretic peptide monitoring before every cycle during anthracycline chemotherapy and 3 months and 12 months after the therapy completion is recommended in high and very high risk patients. This also has a class 1 indication. So we'll move on to the next one. This basically gives a summary of all that has been mentioned already. And this is for patients who are on anthracycline chemotherapy, the surveillance protocol. So again, we always refer to this. We have to categorize the patient into low risk, moderate, high, and very high risk. And that would determine how frequent ECG is done and how frequent biomarkers are also done, as well as the echocardiography. So we'll now look at recommendations for baseline risk assessments and monitoring during HER2 targeted therapy and in the first 12 months after therapy. So for patients who are to receive or have received HER2 therapy, baseline echocardiography is recommended before HER2 targeted therapy started in all patients. And in patients receiving neoadjuvant or adjuvant HER2 targeted therapies, echocardiography is recommended every 3 months and within 12 months after completing therapy. So neoadjuvant therapy is treatment that is done before patients go for surgery. And the adjuvant is the chemotherapy that they receive after going for a surgery, cardiac cancer-related surgery. So for those in the low risk, HER2 positive who have early breast cancer and also asymptomatic with a normal assessment after 3 months, reducing the monitoring to every 4 months may be considered. And in high and very high risk patients who are HER2 positive with early breast cancer, a more frequent echocardiography monitoring should be considered during treatment. And in patients who have metastatic disease and are HER2 positive, echocardiography is recommended every 3 months during the first year if patient remains asymptomatic without cardiovascular toxicity. Then surveillance can be reduced to every 6 months during their future treatments. So this is recommendation on the use of cardiac biomarkers for patients on HER2 targeted therapy. So baseline natriuretic peptide and troponins measurements are recommended in high and very high risk patients prior to the anti-HER2 targeted therapies. And this is recommended for all patients with a class 1 indication. Natriuretic peptide and troponin monitoring every 2 to 3 cycles during therapy, and then 3 and 12 months after the end of therapy should be considered in high and very high risk patients with HER2 positive early breast cancer. And a baseline cardiac troponin measurement should be considered in low and moderate risk patients. This is post-anthracycline chemotherapy, but prior to starting anti-HER2 targeted therapy. Again, this also summarizes the time at which the various investigations are done based on their risk levels. Okay, so we'll now look at cardiac MRI. This is only recommended in patients who have poor echo windows. And then you also have multi-gated acquisition nuclear imaging. And it's usually the third line imaging modality after transthoracic echo and then cardiac MRI. And it should only be done where an echo or MRI is not available. So it's usually the third line modality. And in most cases, it should be avoided where possible. This is because of the high radiation exposure and the fact that it's not able to give other information on the heart concerning DLS status, pulmonary artery pressure, and the valve anatomy. So basically, this one should be avoided unless the first two options are not available. So recommendations based on the cardiac imaging. Echo is recommended as first-line modality for assessment of cardiac function in patients with cancer. And usually the 3D echocardiography is what is recommended where it's available. And where 2D has to be done, the Simpsons is recommended as the first line before 2D assessment. And GLS is recommended in all patients with cancer having echocardiography. That is, if the GLS is available on the machine that is being used. And cardiac MRI should be considered for assessment of cardiac function when echo is unavailable or non-diagnostic. And the MUGA may be considered only when the TE is not diagnostic and when the MRI too is not available. So we'll now look at how to manage CTR-CD. Okay, so this algorithm is mainly for the management of patients with anthracycline-related cardiac dysfunction. And what we do for these patients will depend on whether or not they have symptoms. So focusing on the asymptomatic first, if a patient is asymptomatic and has a mild CTR-CD, the recommendation is to continue anthracycline with cardiovascular monitoring. And for these patients, if they have a decrease in the GLS value or an increase in the natriuretic peptide, then they have to be started on cardioprotective therapy. Severe asymptomatic, then it is recommended that the anthracycline treatment is interrupted and the patient has to be managed as having heart failure. And this treatment modality is just like any other patients who do not have cancer. So the heart failure management is the same as any other patients, but they should have the treatments interrupted until the cardiac function is restored. And then for the symptomatic patients, for those who have mild symptoms, they will require multidisciplinary team approach regarding the need to either interrupt or continue their anthracycline therapy. So this will be this decision will be taken based on patient's parameters. And for all symptomatic patients, they should have heart failure therapy. For those who are moderates, who have their treatment interrupted whilst they go onto the heart failure treatment. And for those with severe and very severe symptomatic CTR-CD, will need to be discontinued if they are on anthracycline treatment while the heart failure is managed. And when they have to be restarted, then an alternate chemotherapy agent, which is less cardiotoxic, have to be considered. So we'll now look at the various recommendations on anthracycline therapy. So heart failure therapy is recommended for patients who develop symptomatic CTR-CD during anthracycline chemotherapy. And this has the class 1 indication. And the discontinuation of anthracycline chemotherapy is recommended in patients who develop symptomatic severe CTR-CD. And a temporary interruption of anthracycline chemotherapy is recommended in patients who develop symptomatic moderate CTR-CD. And a multidisciplinary approach regarding the decision to restart is recommended. So still on the recommendation for anthracycline, a temporary interruption of anthracycline chemotherapy and initiation of heart failure therapy is recommended in patients who develop asymptomatic moderate, or severe CTR-CD. And a multidisciplinary approach regarding the decision as to when to restart is recommended in all patients with moderate or severe asymptomatic CTR-CD. And the continuation of anticycline chemotherapy is also recommended in asymptomatic patients who have a normal EF and who have developed a significant fall in their GLS. So basically those with subclinical LV dysfunction, they can continue on their anthracycline treatment whilst they are put on cardioprotective therapy. And asymptomatic patients who have a normal ejection fraction and who have developed significant fall in their GLS should be considered for an ACE inhibitor or ARB or a beta blocker. And this has a class 2A indication. Again, asymptomatic patients who have a normal EF, who have developed an increase in their troponin level above the upper limit of normal, should be considered for an ACE, ARB, and or a beta blocker as a cardiac protective measure. And asymptomatic patients who have a normal EF, who have also developed an increase, this time their natriuretic peptide, may be considered for cardioprotective therapy treatment. Okay. So we are still on the anthracyclines. So for patients who have to be restarted on chemotherapy after an interruptions, usually consideration of a liposomal anthracycline may be considered with in patients with moderate or severe symptomatic or symptomatic CTR-CD who require further anthracycline chemotherapy to reduce their risk of future cardiotoxic risk. But for those who may not necessarily require anthracycline, they can be put on alternate drugs with less cardiotoxic effects. And dexrazoxine, which is an ion binding or an ion binding agent, may be considered in patients with moderate or severe symptomatic or symptomatic CTR-CD who require further cycling chemotherapy to reduce their risk of future and cardiovascular toxicity. So this diagram is on the management of patients with HER2 targeted therapy related cardiac dysfunction. So again, we start with the asymptomatic patients. So those who have asymptomatic mild CTR-CD can be continued on their anti-cancer therapy with cardiovascular monitoring, and then be started on cardioprotective therapies. So in this case, ACE or ARB or beta blocker. Those with asymptomatic moderates will still have to continue on their cancer treatment and will require more frequent cardiovascular monitoring. For those with severe asymptomatic CTR-CD, will need an interruption of their HER2 targeted therapy whilst they are managed as heart failure. And then for all symptomatic patients with CTR-CD, will have to go on heart failure treatment. Those with moderate to very severe symptomatic CTR-CD will require interruption of their treatment until their heart failure function reverts to normal. So HER2 targeted therapy induced symptomatic CTR-CD. So the heart failure therapy is recommended for patients who develop symptomatic CTR-CD. So this is what has been mentioned in the previous slide. So I'll skip these slides. Okay, so this slide also shows the room for de-escalation of heart failure therapy. As we know, for heart failure, for other conditions, usually don't de-escalate their therapy. But in cardio-oncology, there is room for de-escalation of their therapy. And so for mild to moderate cases, of patients who are deemed to have mild to moderate CTR-CD, when they have a full recovery after the treatment, then they have to be assessed with a multidisciplinary team to take a decision on whether they can be of the heart failure treatment. And the decision to do this will depend on their risk level at the end of the treatment. So if at the end of the treatment, their risk level is low, or they are deemed to have a low risk, then they can be considered for winning of the heart failure therapy. However, if their risk at the end of the therapy is still high, then they have to continue on the heart failure therapy. So we'll now look at hypertension in patients with cancer. Hypertension may be caused by cancer therapy itself. This usually occurs commonly in patients who are on vascular endothelial growth factor inhibitors, cisplatin, and also some cancer medication like NSAIDs and steroids. As we know, stress plays a critical role in hypertension, and the diagnosis of cancer itself is a stressful event as well as the cancer treatment. So all these stresses can also increase the patient's blood pressure as well as the pain that they go through as a result of the cancer and its treatment. And again, most patients with cancer are usually sedentary, and that also increases their risk of developing hypertension. And most of the cancer therapies that causes hypertension can also cause CTR-CD. And ACE inhibitor or ARBs are usually considered as the first line therapy for patients who have cancer and also hypertension. And a combination therapy with an ACE inhibitor or ARB with a calcium channel blocker is recommended if blood pressures are usually above 160 over 100. Okay. So these have been mentioned already, except this one. So diltiazem and verapamil are not recommended to treat arterial hypertension in patients with cancer. And this is due to their drug-drug interactions. So in severe hypertension, where blood pressure is usually above 180 over 100, cancer therapy is usually deferred until the BP has been controlled to below 160 over 100. In patients with resistant cancer therapy-related hypertension, spironolactone and oral or transdermal nitrates and or hydrolazine can be considered as an additional treatment modality. Again, so this table is also a summary of what has been mentioned. So when the systolic pressure is above 160 and diastolic above 100, the patient has to be started ACE or ARB or in combination with a calcium channel blocker. But if the BP is below 160, 100, then an ACE inhibitor or ARB alone can be started. Beta blocker, spironolactone or nitrates are only added if blood pressure is considered as resistant. This table again is on the management of hypertension and also based on patient's prognosis. So it gives various cutoff above which treatment has to be started And this is based on the patient's expected life expectancy. So, for instance, for all cancer survivors, their blood pressure has to be treated with a class 1 indication if their BP is solid BP is above or between 135 and 139 millimeters of mercury. For looking at this one, for instance, for patients with metastatic cancer, who have prognosis of more than 3-year survival, their blood pressure should be treated when it's above 40 systolic. However, for patients with metastatic cancer with poorer prognosis, for instance, those with prognosis of between 1 to 3 years, their blood pressure must be treated when it's above 160 systolic, but above 140, we may consider treatment. Again, for those with poor prognosis, metastatic cancer with poor prognosis of less than 1 year, their blood pressure is usually recommended for treatment when it's above 160 systolic, and they may be treated when the systolic BP is above 140. So the treatment modalities, as mentioned, usually beta blocker, ACE inhibitor or ARB, and also statins. For beta blocker, what is mainly recommended is carvedilol, nebivolol, and bisoprolol. This is mainly due to their antioxidant properties and also help to prevent CTRCD. Metoprolol has been found to be neutral, therefore not helpful in preventing CTRCD. However, propranolol has been found to be harmful, so that one has to be avoided as a choice of beta blocker when managing cancer patients with hypertension or CTRCD. And the ACE inhibitors, usually the most recommended ones are the tissue ACE inhibitor, even though any of these ACE inhibitors are also recommended. So perindopril, enalapril, ramipril. This inhibits the production of reactive oxygen species. Statins have also been found to play a role in the management of CTRCD, and this is mainly because they inhibit the production of reactive oxygen species, and also inhibits topoisomerase 2 mediated DNA damage. So topoisomerase 2 beta is found on cardiac myocytes and is usually bound by anthracyclines. So this picture shows the various chemotherapeutic agents, the mechanism of action causing CTRCD. So for instance, the alkylating agent such as cyclophosphamide causes inhibition of DNA transcription, and this leads to impaired protein synthesis and further leads to LV dysfunction, heart failure as well. The HER2 targeted therapies also causes inhibition of DNA transcription. Anthracycline causes DNA damage as well as inhibition of DNA transcription and also inhibition of topoisomerase 2 DNA repair. It also shows where the various drugs as the ACE inhibitor, beta blocker, also and statin, as well as the statin also acts. So basically the beta blockers, ACE inhibitors and statin all reduces reactive oxygen species, which play a key role in heart dysfunction when it comes to chemotherapy. So there's rasusin, which is an ion chelating agent. This drug inhibits the anthracycline ion complex, thereby preventing ion catalyzed oxidation stress and the disruption of cardiac ion homeostasis. It also decreases the formation of reactive oxygen species and also inhibit the formation of topoisomerase 2 beta DNA cleavage complex, which impairs DNA repair. So besides the pharmacological treatments, the non-pharmacological therapy is also very important when it comes to treatment of cancer therapy-related dysfunction. So for these patients, healthy diet is highly recommended. And what is highly recommended is the Mediterranean diet, which is high in fruits, fiber, and vegetables, and also nuts. Smoking cessation plays an important role, and also regular exercise, mainly aerobic exercise and weight control, also help in the management. So we'll now look at cancer therapy associated thrombosis. These are mainly the VTEs and arterial thromboembolism that's associated with cancer is treatment. So cancer usually confer about 5 times higher risk of developing a VTE and also a 2 times risk of developing an arterial thromboembolism. VTE are the second leading cause of death in patients with malignancies, and it actually may be the first clinical sign of a malignancy. And it's followed by a 5-year incidence of diagnosing malignancy during the subsequent 12 months. So usually when patient presents with VTEs with no obvious cause, we should always think of malignancy as a possible cause and screen for it based on patient's age and gender. In terms of anticoagulation therapy, patients with cancer have both increased thrombotic and bleeding risk associated with their specific cancer location. Usually, those with GI or intracranial cancers who have a high risk of bleeding. And several large randomized control trials and meta-analysis have shown that low molecular weight decreases the risk of recurrent VTEs by about 40% compared to VKs like warfarin. But they both have similar bleeding risk. The VKs are characterized by their unpredictable anticoagulation effects and a low time in therapeutic range in patients with malignancy. And this is due to critical drug interaction, GI toxicity, and also in most cases, liver dysfunction in these patients. So on the various recommendation on anticoagulation therapy, apixaban, edoxaban, and rivaroxaban are recommended for the treatment of symptomatic or incidental VTEs in patients with cancer who have no contraindication to be on this medication. And low molecular weight heparin are recommended for treatment of symptomatic or incidental VTEs in patients with cancer whose platelet counts is above 50,000 per microliter. And then in patients with cancer with platelet counts that is below between 25,000 and 50,000 per microliter, anticoagulation with a half dose low molecular weight may be considered after a multidisciplinary discussion. And then prolongation of anticoagulation therapy beyond 6 months should be considered in selected patients with anti-cancer, including metastatic disease. And again, extended prophylaxis with low molecular weight heparin for 4 weeks post-operatively is recommended for patients with cancer undergoing major open or laparoscopic abdominal or pelvic surgery with low risk and a high low bleeding risk, but has a high chance of developing a VTE. And prophylactic low molecular weight heparin for primary prevention of VTE is indicated in hospitalized patients with cancer or those with prolonged bed rest or reduced mobility in the absence of bleeding or other contraindication. Okay, so we'll now look at recommendations for atrial fibrillation in patients receiving anti-cancer treatment. So the CHA2DS2-VASc score. So as we all know now, the CHA2DS2-VASc is without the sex category. So the CHA2DS2-VASc score should be considered for risk stratification for stroke and systemic thromboembolism, taking into account that it may underestimate the actual thromboembolic risk. So this has a class 2 indication for the use of CHA2DS2-VASc score to determine whether or not to anticoagulate. And then long-term anticoagulation is recommended for stroke and systemic thromboembolic prevention in patients with cancer, with atrial fibrillation, and a CHA2DS2-VASc score of 2 in men. So currently it will be 2 in both men and women, not 3 in women. And a long-term anticoagulation should be considered for stroke and systemic embolism prevention in patients with cancer, atrial fibrillation, and a CHA2DS2-VASc score of 1 for both men. And patients with cancer and atrial fibrillation and CHA2DS2-VASc score of 0 may have a high thrombotic risk than patients without cancer. And these patients may be considered for therapeutic anticoagulation after consideration of their bleeding risk. So this has a class 2B indication. So left atrial appendage occlusion may also be considered for stroke prevention in patients with cancer and atrial fibrillation and who have a contraindication to be on a long-term anticoagulation. And this should also be, the life expectancy should also be considered. So usually it's indicated for patients whose life expectancy is above 12 months. And anti-platelet therapy or prophylactic low molecular weight heparin are not recommended for stroke or symptomatic thromboembolic prevention in atrial fibrillation patients with cancer. And heart rate control strategy, preferably with a beta blocker, should be considered in patients who develop well-tolerated atrial fibrillation whilst they are receiving active cancer therapy. So on radiotherapy, the heart is considered as radiosensitive and an organ at risk during radiotherapy, and radiation exposure to the heart should be kept as low as reasonably achievable because usually there is no safe dose when it comes to the heart and radiotherapy. No dose is considered safe. So as much as possible, everything should be done to reduce the radiation exposure to the heart. Radiotherapy increases the risk of developing subsequent cardiovascular disease and peripheral artery disease. And currently there's an ongoing debate regarding the safest radiation dose to give to prevent cardiac dysfunction. Also, which cardiac substrates are the most sensitive to radiotherapy-induced injury? And again, the most appropriate strategy to minimize radiotherapy-related cardiovascular dysfunction is still being debated. Cardiovascular risk categories for radiotherapy depends on one, the dose distribution, exposure of specific cardiac substrates, and then the patient's underlying cardiovascular risk factors. And strategies to prevent cardiovascular complications from radiotherapy have focused on reducing radiation exposure of the heart and cardiovascular substructures during cancer treatment. And this includes the following. One is the modification of cancer management to omit radiotherapy completely where it is possible. And also modification of the dose and volume of radiotherapy treatments where that is also possible. And the other way to reduce these effects is modification of delivery technique to reduce cardiac radiation exposure. So this usually includes breath hold, respiratory gated technique, especially in breast cancer, lymphoma, and then lung cancer recurring radiotherapy, and the use of image-guided radiotherapy to ensure accurate delivery, and proton beam therapy. So that's also another way to reduce cardiovascular complications from radiotherapy. And the incidence of cardiac events following radiotherapy may vary according to patient's risk factor and the synergistic effects of radiation and other cytotoxic cancer therapy that patients is placed on. There are no known radiotherapy-specific secondary preventive measures. For example, the use of drugs like ACE inhibitor or ARBs for in other chemotherapy regimes. But for radiotherapy, there's no non-preventive therapy. So the aim or one major way to reduce cardiac dysfunction is to optimize the modifiable risk factors before, during, and after radiotherapy. So the classification of radiotherapy recommendations, a baseline cardiovascular risk assessment and estimation of a 10-year fatal and non-fatal cardiovascular disease risk with score 2 or the score 2 OP is recommended. And as we know, score 2 is region specific and is more for European patients. So for African patients, we may have to rely on the WHO risk assessment to assess their 10-year risk of fatal and non-fatal cardiovascular disease. And a baseline echocardiogram should be considered in patients with previous cardiovascular disease before radiotherapy. To volume includes the heart. So just a short one on Takotsubo syndrome. Takotsubo, as we know, is stress-related cardiomyopathy. And as mentioned earlier, diagnosis of cancer and its treatments is a very stressful event. And Takotsubo is one of the cardiomyopathies that we may encounter in cancer patients. So the recommendation when it comes to Takotsubo syndrome is mainly to try and distinguish it from an acute coronary event or an MI. So when it comes to the recommendation on Takotsubo syndrome, coronary angiography is recommended, and this is mainly to exclude acute coronary syndrome. And cardiac MRI is also recommended to exclude myocarditis and MI. And in patients with Takotsubo syndrome, QT prolongation drugs are not recommended during the acute phase. And then on coronary artery disease and then acute coronary syndromes. So patients with cancer are at an increased risk of developing a coronary artery disease. And this is because of the shared cardiovascular risk factors and cardiovascular toxicity of cancer therapy, and also compounded by the cancer-induced pro-inflammatory states, as well as these pro-thrombotic states. So all this will increase the patients with cancer, patients' risk of having a coronary artery disease when they have cancer. And the proportion of acute coronary syndromes patients with the diagnosis of cancer is increasing, and this constitutes about 3% of patients who present with acute coronary syndrome. The diagnosis of ACS is usually based on the same principles as in patients who do not have cancer. So it's mainly based on their symptoms, their ECG findings, and serial heart activity, troponin elevation. Patients with cancer may present with atypical symptoms, and this may mask the diagnosis of ACS. And these symptoms usually are quite similar to the symptoms that the cancer or its therapy may present with. So one must have a high list of suspicion to diagnose acute coronary disease in a patient who have cancer and also on treatment. Okay. So some of the recommendations. An invasive strategy is recommended in patients with cancer presenting with STEMI or high-risk STEMI, acute coronary syndrome, who have a life expectancy of more than 6 months. Okay, so as we know already, to categorize STEMI patients as either low, moderate, or high risk, we can use scores like the TB score or the GRACE score. And again, a conservative, non-invasive strategy should be considered in patients with a poor cancer prognosis. And by this, we mean patients with life expectancy of less than 6 months and or a high bleeding risk who presents with STEMI or STEMI ACS. And a temporary interruption of cancer therapy is recommended in patients where the cancer therapy is suspected to be a contributing factor to the ACS that they are presenting with. And also a short-term dual antiplatelet therapy strategy should be considered in patients with cancer with very high bleeding risk who have been treated with PCI or an ACS. So in this case, a short-term DAP therapy will be anywhere between 1 month to 3 months, depending on the patient we are dealing with. And then we have some class 3 indications. So in patients with cancer with thrombocytopenia and acute coronary syndrome, aspirin is not recommended if the platelet count is below 10,000 per microliter. And in patients with cancer and thrombocytopenia and ACS, clopidogrel is not recommended if the platelet count is less than 30,000 per microliter. And prasugrel and ticagrelor are also not recommended when the platelet is below 50,000. Okay, so due to a potentially high bleeding risk, for example, patients with active GI cancer, the preferred antithrombotic strategy after a drug-eluting stent consists of a dual antiplatelet therapy with aspirin and clopidogrel, but not the newer forms of the P2Y12 antagonists. Dual antiplatelets should be kept as short as possible, usually between 1 to 3 months in patients with a high bleeding risk. And in patients with need for therapeutic anticoagulation and antiplatelet therapy, a NOAC or a single oral antiplatelet, preferably clopidogrel, is the default strategy after a short period of triple antithrombotic therapy. And usually this is after about a week in hospital. Okay, so I'll skip this one. So in conclusion, we'll look at some key messages from these guidelines. So firstly, cardio-oncology providers must have a broad knowledge of cardiology, oncology, and hematology with an interdisciplinary communication. And as a guiding principle, the practice of cardio-oncology, is to minimize unnecessary cancer therapy interruptions. And the decision to do this is usually based on a multidisciplinary team discussions. Echocardiography and blood-based biomarkers are the main methods used in the assessment and monitoring of cardiotoxicity. And there is a new recommendation that supports the practice of continuing trastuzumab in patients with asymptomatic moderate CTR-CD whose EF is below 40 to 49%, whilst putting them on cardioprotective therapy. There's also a new recommendation that supports the practice of de-escalating cardioprotective medications in cancer survivors who have recovered from cardiac dysfunction and also are at a low risk of future cardiovascular events. Also very important that patients must receive psychological support when needed, and a clear, accurate information about their condition must be mentioned to them to help engage them to play an active role in the management of their treatments, and also to increase their adherence to the cancer and the cardiovascular therapy. Some class 1 indication in this guideline is the use of low molecular weights as prophylaxis in VTEs in patients with multiple myeloma and VTE risk factors. And other class 1 indication in this is the treatment of VTE with apixaban and edoxaban or rivaroxaban in patients with VTE and cancer. And again, the treatment of VTE is low molecular weight heparin in patients with cancer and platelet counts above 50,000 per microliter. Cardiac magnetic resonance imaging for evaluation of patients with suspected amyloid light chain cardiac amyloidosis as a class 1 indication. And then lastly, we'll look at some of the class 3 indications in this guideline. So number 1 is to avoid QT prolongation drugs in patients with cancer and tachytubal cardiomyopathy. You should also avoid aspirin in patients with cancer and thrombocytopenia if platelet is below 10,000 per microliter. Sorry, not 1,000 as indicated, 10 to be 10,000. And we should also avoid clopidogrel in cancer patients when platelets count is less than 30,000, and also avoid prasugrel and ticagrelor if platelet count is below 50,000 per microliter. Other class 3 indication is aspirin or low molecular weights are not recommended for primary prevention of stroke or symptomatic thromboembolic embolism in patients with cancer and atrial fibrillation. And then diltiazem and verapamil are not recommended for treatment of hypertension in patients with cancer. And this is mainly due to their drug-drug interactions. This table basically summarizes most of the things that have been said, encompassing the risk classification, the preventive modalities, the monitoring tools, and also the pharmacological and non-pharmacological treatment modalities of CTR-CD. So these are my references. So I'll end here and then take contributions, questions, or comments. Thank you very much.
Thank you very much, Dr. George Ofosu, for such a brilliant and detailed presentation. We are very grateful. Please, at this point, open the floor for questions, contributions, and congratulatory messages. Thank you.
Thank you, Dr. George, for wonderful presentation. In fact, this will be the first time or second time I'm hearing this lecture in this kind of rare condition. So it's an eye opener for me. It was a very interesting one. I mean, well delivered. Thank you very much. But I have some a list of verifications. When you classify the patient into mild symptomatic, moderate symptomatic, symptomatic, and you go to be symptomatic, what do you use to score them to say this is mild, moderate? Because I don't know, that table that you showed that shows like MH, M1, M2, VH. Is it that the score is attached? This point is called 1. Or how do we calculate the score? Because at the point when you were classifying the patient, when you came in, you said one risk factor. Where do we pick out this? Because the table that, so I don't know how to, what do I see in the patient? Say this is low risk, this is as it were. That's
Okay.
the first question. Here, is it that yes, score assign 1? Let me take for example now. And let's go to the other slide that had the parameters, the different parameters.
This one? Oh,
Yes, let's just say somebody is 80 years now and they want to
okay.
take, and let me sit down. Somebody is 80 years, he has multiple myeloma, 80
Okay.
years, has multiple myeloma, and is going to take RF and ME inhibitor. What did I put
Okay.
this
So
patient?
okay. So with the age 80 years and above, who is going to take this medication? Based on the age alone, we have moderate 1. So that gives a score of 1. But that doesn't end there. You have to look at all the other parameters. As if you have hypertension, if you have hypertension, that also gives you a moderate 2 score. So if you add the 1 and 2, that gives you score of 3. If she has kidney disease, that'll give you a score of 1. So that means patient is now 4. So
Okay,
basically, you have to
so
go
that
through
is
all these parameters, and at the end, you get a
one
total
aside
score for the
other.
patient. Yes, you have to go through this one, that one. So you have gone through all the baseline risk factors. Then you get a total
So I
score
cannot
for the
use this.
patient.
So I cannot use, for example, I cannot just use that somebody is 80 years and is going to take
Okay.
anthracycline, and I see it's a high risk patient because of that age.
So if you are 80 years and above, you're going for anthracycline. Then that alone puts you at a high risk.
Already.
So regardless of whatever the others will show, you are still high risk.
Okay. Okay, so that's the first
So your
question.
money.
It's clear. That's
Okay.
it's clear. Then the second one is this life expectancy. This is the guideline when you were saying is somebody life.
Hello.
Sorry, I have sorry. So I was talking about the life expectancy. This is the guideline when you said
Okay.
as a point, if life expectancy is more than 5 years, you have to do this or do that. So how do we know this patient life expectancy?